Hello, my name is Kimberly Nieto. I'm a student physical therapist assistant. Today I'll be doing a presentation over the ACL, or the anterior cruciate ligament, in the Accelerated Post-Op Reconstruction Program. So what is the ACL? The ACL is the primary restraint to forward motion of the tibia. It prevents the tibia from sliding too far forward. It also contributes stability to other movements at the joint, including the angulation and rotation at the knee joint. In this picture here, is showing you what a normal ACL looks like. So what causes the ACL to tear? So it can be torn in several ways, actually. Changing direction rapidly, stopping suddenly, slowing down while running, landing from a jump incorrectly, or direct contact or collision, like a football tackle. In this picture, you'll see a normal ACL and what a torn ACL looks like. So this program is the Accelerated Post-Op ACL Reconstruction Rehabilitation Program, and this program is typically used with your athletes and younger patients, just because the level of activities the patient will be doing and the length of time that they're expected to do them. So phase one is the inactive phase. So the goals in this phase are to decrease pain, decrease any muscle spasms, decrease edema, protect the surgical site from excessive stress, and maintain the conditioning levels. So during this time, you would utilize modalities for pain and edema. The patient would be using a knee brace at 0 degrees of extension, and then you would do grades 1 and 2 of joint mobilization. Weight bearing as tolerated, and maintain the conditioning levels with special attention to the hip and the ankle. So during this program, the patient will ambulate with crutches and have weight bearing as tolerated with full knee extension immediately following their surgery. So I pick straight leg raises. 2 days post-op, their passive knee extension will be at 0, and active hip exercises would begin, including straight leg raises and any ankle range of motion. So 3 sets of 10, 5 to 7 times a week. And this is a good exercise to use and see where your patient's at, because you can progress them using cuff weights once there's no extensor lag and that patient can maintain full extension. So for physical agents, neuromuscular electrical stimulation for 10 to 15 minutes to the VMO, and then ice after treatment for about 10 to 15 minutes as well. So during phase 2, this patient should be ambulating without crutches. They can begin their active range of motion exercises for the knee and begin close kinetic chain exercises and proprioception. So during this phase, the active phase as it's known, the goals are to increase the range of motion, increase quad strength, reduce scar adhesions, increase muscle endurance, ambulate with the brace unlocked to week 3, and then discontinue, and then no pain, to decrease pain, spasm, and edema. So during this time, treatment would consist of beginning quad sets, any hip exercises, early proprioception, soft tissue mobs, range of motion exercises for the knee, muscle endurance to tolerance, continue with patellar mobs, gait training without crutches, and then you could use the stationary bike, do mini squats, hamstring curls, heel raises, static squats. And at 3 weeks, the patient is allowed to go in the pool if they have access to one. So they can do pool jogging. They could use the stepper, the ski machine. They'll be able to stand on their heels and their toes alternatively. And again, you would continue with proprioception and maintain their conditioning levels. So the static squats I chose here would be to 90 degrees, 3 sets of 10, about 3 to 5 times a week, and then you can add in dumbbells once the squats are stable. So for physical agents, continue with the NMES before therapy, and then icing for 10 to 15 minutes following therapy and at the end of their day. Pulse ultrasound can also be used during this time to stimulate the tendon bone healing. It's used in conjunction with NMES or can be alternated. So phase 3, weeks 4 to 12. So by the end of the first month, the patient should have their flexion to about 115 degrees and have full extension. You would continue muscle endurance, proprioception, range of motion as needed, and begin early functional activities. So the goals during this time are full range of motion, increase the strength and endurance gradually, increase proprioception, maintain their conditioning levels, have good soft tissue mobility, and have normal joint mobility. So for treatment, you can begin treadmill walking at 6 weeks. Once the patient has full active extension and their flexion is 115 to 120 degrees, and they have good isometric quad strength. You would also continue with strength progressions, early functional exercises, and then do grades 3 and 4 joint mobs as needed. So for this phase 3, I chose side to side lunges, 3 sets of 10, because it does engage the muscles. And you can add in dumbbells with starting with the 5 pounds once these lunges are stable and work up as tolerated. So side note, the patient should not be having any increased pain or edema or have any sensation of knee laxity. So for physical agents, I chose NMES again, and this would be before therapy and ice after. And by this time, pulse ultrasound is still used as needed. So for phase 4, the patient will begin plyometric activities along with running activities and progress to sprinting. So the goals for phase 4 are to perform their functional activities properly, perform sport and activity specific exercises, and return to full participation. So this is where you would discharge them. So during this time, sled pushes would be a good exercise to start with. Having them go do 1 set of 10, 1 set of 8, and 1 set of 6, probably 3 times a week at this point, and then starting with 20 pounds on the sled and then working their weight up each session if they are tolerating well. For physical agents, we would do ice after therapy for about 10 to 15 minutes, just depending on how the patient is feeling.
There go, drive! Come on, gotta work! That's 1. Yep. Last 1, let's go! Come on! Knees, pump, push! Right in.
So phase 5, week 16 to discharge. So during this phase, a patient continues plyometrics for their lower extremity, including stair running, jumps, and eccentrics. The patient will also perform sport and activity-specific exercises to at least pre-injury levels. Single leg hops are a good option to have, 2 sets of 15, 1 set for height and 1 set for distance. And again, 3 times a week, and using ice after therapy as needed. So when is this patient ready for discharge? So before they can be discharged and return to their activity, patients must pass all aspects of activity or sport-specific examination, have full motion, strength, and normal proprioception, and be pain-free without edema post-exercise. So post-discharge, the patient will continue their previous hamstring, quad, and calf stretches and do dynamic warm-up prior to sports or activities. The patient will also return to full participation with no pain, normal strength and mobility, and execution of activities.